Good evening. My name is Michael Fine. I'm the president and board chair of a new organization called Primary Care for All Americans, an organization that's working to build a movement to create a healthcare system for the United States that's for people, not for profit. And we'll start by building a healthcare system that provides primary care to all Americans in every American neighborhood and community. It's my great honor to welcome everyone tonight, and in particular, my dear friend and colleague, Chris Kohler, who will be our moderator and is the president of the Millbank Fund, as well as the former health insurance commissioner for the state of Rhode Island, and many other things. Chris, take it away.
Thank you very much, Michael. Thanks to the folks at Primary Care for America for organizing this. Thanks to our panelists for offering their expertise. And thanks to all of you for showing up and being interested in an issue that I think has great significance for the prospects for a healthy America. As Michael said, I'm president of the Millbank Memorial Fund. We are a operating foundation. Our mission is to improve population health and health equity by connecting leaders and decision makers with the best evidence and experience. I want to get right to the show, have our panelists introduce themselves. It's a very accomplished group with different perspectives on the question of the prospect of the presence of private equity in our healthcare system and what those incentives mean for patients and for clinicians. And then after they introduce themselves, I'll go through the structure of the evening. So Maureen Tasic, if you want to start first, then we'll have Mitchell Lee, Yael Lehman, and Michael. So, and then I'll come back to me. So Maureen.
And can I just clarify, would you like me to introduce myself? I am Maureen Tasic. Feel free to call me Mo. I'm the investigations editor at the American Prospect, and I've been following a lot of private equity in hospitals and healthcare related stories over the past few years, really since COVID. And sorry, should we introduce all of one another first?
Let's do introductions first, then we'll go back around.
All right, thanks. So I'm going to choose Yael to be next.
Cool, thanks, Mo. Great to see everybody tonight. My name is Yael Lehman. I'm the interim executive director at Families USA. Families USA, for those of you who don't know much about us, is a nonprofit organization. We're based in Washington, D.C. We've been around for like 40 years, something like that. And we're very involved with the passage of the Affordable Care Act. We're dedicated to achieving high quality, affordable healthcare and improved health for all with a focus on consumers. And I will kick it to Mitch.
Thanks. My name's Mitch Lee. I'm an emergency physician and actually grew up in Massachusetts, went to Northeastern undergrad in Boston and University of Massachusetts Medical School. And I'm founder of the group Take Medicine Back, which is named to take the profession of medicine back from corporate interests. And I'll expand upon that a little bit more later, but suffice to say, 3/4 of us are employed by corporate interests, and those corporate interests are not as benevolent as they used to be, if they ever were. And that's a problem.
That's great. Thanks, Mitch. I'm sorry. Did you want to say anything else? I didn't mean to cut you off.
No, I think we're going back around. So that's
right. Okay. So here's the structure. First of all, you folks all know the session's being recorded. You consented signing in, but I just want to remind folks of that. If you're so inclined, I'd encourage you to put your name and your hometown or in the chat, just so we can get a sense of the geographic breadth. My senses are folks from a lot of different places calling in who are concerned about this. And then the structure is we're going to have our guests speak for about 7 to 9 minutes each. And then we'll have time for questions and answers afterwards. There is a batting order that we set up here. As folks talk, I would encourage you, if something comes to mind, put your question in the chat. We'll be collecting them as we go along. If you want to ask them yourself, put your name next to it. We'll make sure that you get to ask the question. And then depending on the volume of questions and the level of interest, we may have folks able to raise their hands at the end and also ask some spur of the moment. But as you're provoked by stuff, please feel free to throw things in the chat and have a conversation as we go along with this. We're going to start with Mo, who, as she noted, has spent a lot of time with this. And Mo, I want to kind of, we're starting with Steward in Boston. And then I think we're going to connect the dots to the world of private equity more generally. But it's 10 years ago, or a little bit, 10 or 12 years ago, the Diocese of Massachusetts wants to get out of the healthcare business. They're looking at either shutting down hospitals completely, or and just meaning limiting access to care, kicking healthcare workers out on the streets, or they've got to peel apart their hospitals and send them to those with the deep pockets, thus increasing their economic leverage in a market that's already pretty consolidated. Along comes another source of capital. They're outside, it's new money, they're going to invest a lot. They're presenting an alternative to either shutting down these hospitals or sending them into bigger places. What's so wrong about that? That's sort of how the diocese got into the business of selling their hospitals and how Steward came to acquire it. So what could possibly go wrong from a policyholder or a politician standpoint? This is the best alternative. The other options look pretty bad. We've either got to shut them down or consolidate them. So what has happened as a result of that decision?
Well, it's funny because as you were saying that, I do a lot of real nightmarish stories in healthcare that I have stumbled upon over the past few years, nursing homes and hospitals. Are ex-Catholic hospitals that were privatized. It seems to me that there's like the most dramatic fall off, and I kind of wonder, who was spearheading all of these sales? Was it, were they fire sales driven by legal bills? I remember, I remember about. It must have been 16 years ago. There was this gentleman who was like, good friends with Bill Clinton and Ron Burkle. He was sort of a con artist. His name is Raffaello Folieri, and he told Bill Clinton, and Anne Hathaway was engaged to him briefly, but he told everybody that he was helping the Vatican sell off their real estate assets to pay their bills, legal bills tied to their horrific sex abuse cover-ups and scandals. So I really don't know who was on the seller side of this transaction, or what was actually what anybody was thinking. But in these transactions, generally there's the seller is the less informed. There's an information asymmetry between seller and buyer. And certainly the smart money was on the buy side. So Steward was formed in 2010, and it was sort of the project of the Catholic hospital group, the Caritas Christi hospital system in Massachusetts. I think they had 5 hospitals that were helmed by a very swashbuckling cardiac surgeon named Ralph de la Torre, I believe, Ralph de la Torre. I'm not sure which pronunciation he went with. He seems more like a Torre to me. He was, a really, really charismatic figure, Everyone seemed to think he was a brilliant mind, but he was also somebody who has a taste for the high life and always did. So he what had been running the Caritas Christi health hospitals for a couple of years, and he links up with Cerberus somehow. Now, Cerberus is a private equity firm. If you don't know what a private equity firm is, it's kind of like in the 80s they called them corporate raiders. I don't know why we stopped calling them corporate raiders. They rebranded themselves private equity. That is a really poor name what they do, because what they do is generally zero out the equity. So they will take over an asset, a company, a chain of hospitals, a chain of retailers. They tend to put very little money down, sometimes 10%, sometimes 20%, and the rest make up the rest of the purchase price in debt. So right away, it's not equity that they leave there. It's not cash investment that they're putting into anything that they invested. It is debt. And so the outcome, immediately visible to everybody of this so-called investment is disinvestment. And that is what that is why calling it private equity and investment in healthcare, even calling it investment really makes me a little crazy, because this is not investment that they are doing. They are purchasing the asset. They're buying somebody off with other people's money and then sticking the hospital or whatever the asset is. Sometimes it's a factory, sometimes it's a chain of retailers, with massive debt obligations. And they take on so much debt that they have to borrow at pretty high interest rates. Cerberus came out of the Milken era. Steve Feinberg, the founder and CEO, a big-time Republican donor. He was a Michael Milken. He worked at Drexel, Burnham, Lampert. Cerberus is the three-headed dog who guards the gates of hell in Greek mythology. And that is like pretty on the nose in terms of what Cerberus does. Cerberus is really renowned among private equity firms, even because all private equity firms are pretty much follow the same playbook. But Cerberus has a much higher default rate. They're much better at doing the bankruptcy process, and they're much less interested in actually, sometimes you will put a little bit of investment into something because you'll get more money out. Cerberus starts stripping the assets that they own right away. They acquire a company and immediately they're selling off, anything, mortgaging anything that isn't, nailed to the floor and then some. They mortgaged an insane amount of stuff at the Steward hospitals, almost everything, and when we're seeing everything get repossessed from these hospitals. The other day I read on Reddit, a nurse at I think St. Elizabeth's reported that boars had come by the hospital to repossess some of their deli meat. I heard from a physician in Miami that Coke had come by to repossess Cokes, like cans of Coke. So this has been happening for a really long time. It's very dire right now. Cerberus. But Ralph de la Torre is a very convincing character, and he had in mind. I'll say that the idea behind Steward Health seems to be a get rich quick scheme that turned into a get rich quicker scheme. So initially, Ralph had this idea, and I think that it was informed by healthcare policy in Massachusetts, that he was going to buy all these, string all these community hospitals together, and force all of the primary care physicians and affiliated with those hospitals to bring all of their their referrals and bring all of their higher value procedures in-house. And like I said, not just primary care physicians. Obviously, he bought off and formed alliances with pretty high profile medical practices in Boston. And
Bo, I'm giving you the 2-minute warning. I promised you
God.
that I would do that.
Oh,
Okay.
shoot. Okay, so I didn't realize that. God, talk and talk. Anyway, it seemed like he was trying to initially take advantage of a loophole, or loopholes opened by the Affordable Care Act, in something known as an ACO, an accountable care organization. The particular type of ACO structure he had won a lot of waivers from fraud and abuse statutes, and which he kind of overinterpreted as sort of a license to do kickbacks. If you're in the healthcare industry, you understand that's not okay. Physician self-referral, there are all these laws, barring this stuff, and sort of limiting the amount of conflict of interest that a physician can have when it comes to procedures that he or she is prescribing or referring his or her patient for. So it seemed like it was a way to game that. I have lots of evidence amassed. But Cerberus wanted to start making its money back a little bit quicker than that. So they sold off all of Steward's real estate to an Alabama real estate investment trust called Medical Properties Trust. And they sold off this real estate for 1.25 or $1.5 billion. And they pocketed the vast majority of that money. So now these hospitals, which are losing money to begin with, are stuck paying this enormous rent bill. They can't afford it. So Medical Properties Trust, the real estate investment trust, starts trying to slip them back some money so that they can pay their rent. Why did Medical Properties Trust do this? I don't know, but Medical Properties Trust over the years, and that initial sale leaseback was back in 2016. And Medical Properties Trust has found so many ways of giving Steward money to pay them back so that it looks like they're paying rent when they really are just hopelessly insolvent and never going to be able to pay that rent, that has become a total Ponzi scheme. Ralph, Cerberus sold out in 2020. That has to do with this crazy, that has something to do apparently with this crazy ordeal in Malta. We can get into that later. But today Medical Properties Trust had a conference call, and it was Medical Properties Trust. Steward has been insolvent for probably 7 years. It's going to be bankrupt. It's going to have to file for bankruptcy protection. The question is just like, are they going to be able to get DIP financing, which is a whole nother story. Medical Properties Trust looks like it is also probably on the precipice of bankruptcy, although none of their executives, they all seem to have deluded themselves that they're going to dig themselves out of this. Meanwhile, this is happening not just with Steward, but private equity owned hospitals systems all over the country, and a lot of just straight up for-profit hospital systems as well. So we can talk about that. I hate to go on and on, but I will cede my time to the next.
Thanks for laying out the wreckage. It does feel like a Ponzi scheme or a shell game in terms of what's going on. And if folks are interested in this, just yesterday, the latest step was a very strongly worded letter from Governor Healy. There's an article about it in the Boston Globe talking about she's banging on Steward, not necessarily Medical Properties Trust, but part of this is the whack-a-mole, knowing where you should go after, where the money is. The Steward's not alone in this. So Mitchell Lee, as an emergency room physician, you have a firsthand witness to some of the effects of this, not only in hospitals, but private equity is also buying up practices where it can assemble practices, assemble assets, and then basically take advantage of inefficiencies in the way that providers are paid, ramp up the productivity for those physicians, and generate a ton of revenue for the investors, a return on their investment. So what's the effect of this on the practice of medical care and on patients as I go through this from your vantage point? Thanks.
Yeah, thank you. And you've now met Maureen Tasic, who spoke at our first summit and gets in the zone when she speaks. So it's pretty incredible. I think we'll hear a lot more from Mo shortly. So so much to unpack, and I'll try to make it in 7 minutes. And actually, I got a timer in front of me to do that. Okay, perfect. So let me just repeat about private equity. Private equity, leveraged buyouts, the leveraged buyout industry, the corporate raiders. The more I've learned about that, and of course, as a physician and a person who went to school in America, we didn't learn anything about basic personal finance. So as I learned more about personal finance, I figured out, also private equity is essentially just imbuing yourself with high interest credit card debt. And I could have done that myself. It is not an investment. It is a forced extraction that's disguised as an investment. So that's just to frame things a little bit. And yes, I'm an emergency physician and started the group Take Medicine Back in 2019. And we've had 2 virtual summits and 1 in-person summit, which was amazing. We actually had Brendan Ballou, who is the author of Plunder, How Private Equities Plan to Pillage America. And he's also a DOJ federal prosecutor who's our keynote speaker. We're trying to get those videos up soon. Private equity, in our view, at least when they employ physicians, is the most extreme form of the corporate practice of medicine, at least that we've seen so far. So in a little bit of taking a step back in a 30,000-foot view, in the history of medicine in the United States, we have early 1900s, late 1800s, the birth of the modern form of medicine in the US was around 1910. Flexner Report essentially standardized medical education in the United States and said, we've got all these 2-year degrees, and we've got some snake oil salesmen that are just making outrageous claims, cures what ails you. And at the same time, we had the first Gilded Age. Basically, we had the trusts and the monopolies of the early 19th or early 20th century. And there was a recognition that this was a problem. This great concentrated wealth in the hands of the few was causing a lot of problems. And there were kind of 3 reactions to this, 2 that we know pretty well. One, the antitrust movement. The Clayton Antitrust Act and the FTC Act, and Teddy Roosevelt busting the trusts. And then we also had the labor movement, because labor did not have power and they needed to consolidate that power to fight back against these employers, the mining industries, etc. What's less well remembered and less well known is the corporate practice of medicine doctrine that the profession of medicine created. This was basically our profession's response to corporations. And the idea was that physicians maybe should not be employed by lay interests, meaning not physicians, that might influence the practice of medicine for their own profits. So if you were a mining corporation, then if you employed the physician, you're the company doctor, and your diagnoses and things could not be trusted because the mining corporation wanted all the miners to get back to work, and it didn't matter if they were sick and had a black lung, etc. This was turned into state laws in various ways. Massachusetts has some of these, which basically says physicians should not be employed by these for-profit corporations. And many exemptions were made to say that, a nonprofit hospital is okay. Because nonprofits obviously are working in the benefit of the public and they're benevolent and all that kind of thing. That's not really the case in Massachusetts anymore, where we've seen massive consolidation of hospital system, including those that are tax exempt. And now we see something like Steward. Now, at many of these hospitals, the emergency physicians, and I'll speak to that in particular, are not even employed directly by the hospital. And if you're employed directly by the hospital, you do have certain potentially W-2, just regular worker protections. And you also have protections from CMS in terms of due process, so that if a physician speaks out about patient safety issues, then they have due process of the law. Basically, they have a fair trial. Right now, physicians are retaliated against if we speak out even a little bit about patient safety. We can be just removed from the schedule altogether. And I'm going to give myself the 2-minute warning. I've got it on my computer, my screen here. And so we have no recourse. And that means that physicians who are mostly looked at and regarded as on top of the cake are completely disempowered and morally injured. And I'll make a point that I cannot work at my hometown's hospital in Massachusetts, Metro West in Framingham. Tenet Hospital, they subcontract to Team Health, which is owned by Blackstone. And Blackstone and Team Health are known for suing poor patients and garnishing their wages and being responsible for the out-of-network surprise billing crisis. Private equity again. And they weaponized this. And then they kind of threw physicians under the bus in that, because we have no idea what's billed or collected in our names. So the physician workforce as a whole is in crisis. 1 in 5 of us are leaving within the next 2 years. There's 68%, 58% of medical and nursing students don't plan to actually treat patients in their career. It's a stepping stone to administration, because we know that administration and working for the man is pretty much the only way out, other than suicide and quitting or going to New Zealand. So we have been working to revive the corporate practice of medicine doctrine and prohibitions in the country, and there is actually a lot of momentum to do this in the legal community and the political community. And it has to be reinterpreted in a modern world where CMS and Medicaid and even the ACA and its value-based care, Medicare Advantage, medical loss ratio kind of disaster has been encouraging these systems. I will say we've worked very well with Senator Elizabeth Warren, and we're excited for where that goes, and happy to be from Massachusetts in that regard. And they're going to co-sponsor the ER Hero and Patient Safety Act, which will essentially give due process rights to physicians that, like emergency physicians that are subcontracted to these PE groups. And we hope this goes much further than that in the future. I'm 3 seconds over, so thanks.
Well played. Well played. You can tell you're training as an emergency room doc and to move things through the system. Mitchell, thank you very much. I also appreciate that you've got your historical perspective and a sense of response. In the this is an effort to identify the root problems and try to address them, as opposed to simply, we were talking about this before conference started, admiring the problem or lamenting, but really getting at what are the core principles that are at place here. So I would encourage folks, people are doing a great job sharing things in chat, but if you've got questions, feel free to throw them in there. We are going to have time for conversation. Yael, from the consumer's perspective, Families USA has been really influential, not only both in the Affordable Care Act and since then on a number of big things. You guys really helped a lot with surprise bills. You helped a lot with the IRA and pharmacy pricing. Are you going to deliver us from private equity too?
I hope so. We can't do it by ourselves. That's why I'm excited to be here tonight. And I know we'll be talking about some ideas around solutions, but yeah, I really do want to just say, as I start off here, Families USA is very eager to partner with all of you here to do something about this. And the hospital closings, as folks have mentioned, it's a trend across the country. There's all kinds of stuff going on with hospitals right now. There's also a huge consolidation of hospitals happening. The majority of hospital markets in our country are now highly consolidated. And we're also now seeing that private equity is increasingly becoming involved in the US healthcare system. And it's resulting in hospitals closing. And when hospitals close, as we all know, that means people are driving further to get care. They might delay care. That means the ambulance times increase. And it's actually proven that the death rates increase when there are hospital closings. So it's really scary stuff. And I'm glad we're all here to talk about what we can do about it together. I know, like, I live in DC now. That's where Families USA is based. But I lived in Philadelphia for 20 years. And some of you may have heard the example of Hahnemann University Hospital in Philly. It had been around since 1885. It served primarily lower income residents, and then it was purchased in 2018 by a private equity firm. And over the course of about a year and a half, they laid off all the doctors and the nurses and the other workers. And everybody was like, what's up? What is going on? And pretty soon it became really clear what they were interested in doing was selling the land. It was the real estate that was actually of value to them. I don't know if any of you guys have ever saw where Hahnemann was located, but it was actually in a pretty central location in Philly. But so many residents lost access to care, and thousands of employees lost their jobs. But that's just one example of many, many examples that are going on right now. And it's heartless, and we got to do something about it. I guess I'll just say, like, I do want to talk about solutions, but just a little bit about private equity. It's entering the healthcare space at a time when families across our country are already experiencing such a severe healthcare affordability and quality crisis. Almost nearly half of all Americans are reporting having to forego medical care due to the high cost. A third have indicated that the cost of medical care interferes with their ability to secure basic needs like food and housing, and more than 100 million Americans are in medical debt. And we're seeing that private equity is increasingly getting involved with healthcare. Healthcare became the second major sector for private equity investment in 2020. And we're seeing, as of December 2023, a significant and growing proportion of US hospitals were owned by private equity. And we know that private equity has shown itself to play a harmful role in the US healthcare system, worsening our nation's existing healthcare affordability crisis, as I mentioned. And the business model of private equity, as others have mentioned, is fundamentally at odds with delivering high quality, patient-centered care that we need and deserve. So, yeah, I'll just quickly close up this part of my talk by just saying, you know, what others have already said and what all of you already know. Private equity firms apply a very short-term profit business model. And when that's applied to our nation's healthcare system, the consequences are dire for all of us. And it also impacts the availability of healthcare for us and our families into the future.
So, Yael, thanks. It sounds like you're just chomping at the bit. I'm gonna, you didn't take up a whole lot of time. So go ahead and talk about some solutions. Like, what do you
Yeah.
It sounds like you're ready to go for it. So I'll run with it.
Sure. Well, all right. So what can we do about it? That's what I'm really interested in talking with you guys about. First of all, we need to organize, right? We need to build a power base. We need to think about what can we do at the state and the federal level. Some ideas that the staff shared with me, these may or may not sound for example, we need to promote transparency. That's something that people talk about a lot in private equity ownership. Requiring providers to report changes in ownership, also strengthening the antitrust enforcement and oversight at the federal and state levels, with a particular focus on mergers and acquisitions related to private equity activity. I would say also, as we think about preventing hospital closures in general, we want to expand Medicaid. When states fail to expand Medicaid coverage, hospitals are even more likely to close. And when we know that when that when Medicaid expansion states when there is Medicaid expansion in states, it decreases the likelihood that hospitals will close by 62%. We also want to think about, this I thought was an interesting idea. I don't know if you all have heard of something called global hospital budgets. CMS, I guess, has been trying this out in a few states, doing some piloting around this. And maybe some of you know more about this than I do. But the idea is you give a fixed yearly payment per patient served to the hospital, so they get a lump payment up front, as a way to offer more stability to hospitals that might be struggling. So changing the way that we pay for healthcare so that it's not dependent on volume is another idea that some folks have been kicking around. So yeah.
It's great. Thank you very much. I mean, there's a lot of food for thought there. Michael Fine, what's all this got to do with primary care and the organizing mission of Primary Care for All?
Well, it's probably got everything to do with primary care and our organizing mission. Chris, you and I met Steward first in 2012 when they came to buy a hospital in Rhode Island, Landmark Hospital. And I actually approved the sale technically, and then it foundered when they couldn't come to an agreement with Blue Cross. But what I saw then and what I see now is that the regulators have some leverage and some ability to direct things or to make things rational. When you get to the bottom of healthcare, it really looks like no one's in charge. And so we've been kind of drifting without effective leadership and without a real direction. You know, we've seen the number of primary care clinicians shrink. We've seen the population now having only 43% of the adult population having a primary care relationship. You know, and essentially folks with something to sell love that because it allows them to market around the relationship people have with their primary care clinicians, who are often in the position to give them coherent advice that doesn't involve a test, a medicine, or a big expense. And with this shrinkage of primary care has come the alienation of the control of health and health services from communities to big corporations or private equity, you know, or other entities which don't have the interests of communities at heart. And that's really the challenge. We've sort of lost control. There are some 450 or so hospitals that are threatened with closure today around the country. And those are going to result, if they close, in healthcare deserts, where people, particularly in rural areas, don't have access to care. And I think a lot of that is because we turned over control of healthcare to somebody else. Once upon a time, hospitals and hospital boards were all local folks. They were engaged in a charitable mission, trying to take care of each other. And physicians and other clinicians were critical to that mission and were connected to their communities. And that has been kind of swept away in this process. And I would argue that it's not just private equity. There's good private equity and there's bad private equity, just like anything else. But well, I think they're
Show me some good private equity.
All right, we'll talk about that in a bit. But we also struggle with hospitals and hospital systems and pharma and insurance companies and the amount of money they throw around, so that we have something like $718 million a year being spent on lobbying, which is why nothing changes. And so the opportunity at the end of the day is to think about how we can bring healthcare back local, how we can get communities involved to protect themselves, and help them understand that with no one in charge, communities have to be in charge. And so I would second Yael's approach of organizing, organizing at the state level, organizing federally, but even organizing locally, and building a base of organization based in how communities provide primary care to themselves, so that every community has primary care and every person has primary care in every American neighborhood and community. That's where we have to get to. And when communities begin to do that for themselves, we will have connected people who aren't going to let this kind of alienation, this kind of theft of control go on. We've got to get that back, or we've got no future. It's kind of a political observation that we've got to attend to a base. We've got to build that base if we're going to defend ourselves as communities, as states, and as the nation altogether.
Thanks, Mo. You're come back, Mo. You just disappeared. I mean, it's actually not Mo who comes back. Someone else is gonna bring her back.
I disappeared?
Yeah, there you are.
Okay.
What are the prospects for, I keep saying that, no pun intended, prospects of another for-profit healthcare company for, and then I want to go to Mitchell on this, for the kind of organizing that Michael is talking about. That, is, you spend a lot of time kind of documenting the harms of private equity. Are they really going to listen, or what's the cause of action from the organizing that Michael and Yael are talking about? And then Mitchell, get ready. I got a quite related question for you.
Well, I would say that the one very small bit of optimism that I've had like watching this problem, because fundamentally we're dealing with a system, as Andrew Cuomo famously said, it's not a system. It's not a system because, and this is where, physicians need to shoulder some of the blame, although I won't blame them for the American Medical Association. The American Medical Association between 1919 and 1965 was basically like single-mindedly focused on avoiding all government intrusion in healthcare whatsoever, and opposing any kind of government regulation. So where we had sort of comprehensive regulation of our railroads, of our utilities, of our airlines, of all of these, of trucking, of all of these sectors of the economy that are, in antitrust, in antitrust speak, natural monopolies. We never got anything approaching that in our hospital systems. Our hospital systems were in large part the creation of a legislation called Hill-Burton, passed in 1946, sort of drafted by the American Medical Association and Senator Robert Taft, a very right-wing anti-labor senator. And this was their bid to stave off Truman's idea for, healthcare for all. So we have these, and the way that they designed the hospital system is that communities would get matching funds. And the American Medical Association had very strong county affiliates at that time, county medical societies. So the county medical societies really concentrated a lot of the power in our healthcare system in counties and county-like, institutions. So that's how we got these kind of like all of these hospitals across our country. Counties are not very powerful, I don't think, in other ways. I mean, they do run school boards, but counties, in a lot of places, they're especially smaller rural counties, a lot of them struggled with the burdens of running a hospital, especially after Hillburton was sort of defunded. And HCA was the first for-profit entity started by a cardiologist, Tom First Senior, and HCA was the first big company to come up and start privatizing these community hospitals. So it is kind of, a lot of, I've seen everything in this struggle. There are a lot of communities out there that would really like to take back control of their hospitals, but it is a big burden, and it's difficult to handle that financing. So we need better financing for these hospitals. The answer is not to, however, to give them money for nothing. Like the idea of giving Steward capitated payments for the number of patients that they serve, so to stabilize their finances. I mean, that is just going to buy another yacht for Ralph de la Torre. Why we don't have guardrails against this kind of, stealing from our system is because so much of our policy is informed by right-wing lunacy. I mean, is basically all I can, the only thing that I can that I can figure. Why do our, why do we have drugs that cost $1 million a year? We need some controls. We need some, comprehensive regulation, and we don't we have too many lobbyists making all of the policy decisions.
Sure.
So that is the one thing that I would say, that I started this with a cause for optimism, and I never got there. In a lot of industries that have been sort of gutted, you haven't had the fraternity, you haven't had solidarity between the sort of like highly skilled, highly educated workforce and the sort of rank and file workforce. You have a lot of that in healthcare now. You have the doctors learning from the nurses. You have this unbelievably well-educated population in our physicians who, and obviously I have selection bias, the doctors I talk to are really pissed off. But I mean, these are people who went to school, for as much as 10 years after graduating from college to become, cogs in a machine, and they're angry about it, and they're really, really committed and capable of getting together. So we, in Oregon this week, tomorrow, actually, the Oregon State Legislature is voting on a law that will, very gradually, incrementally, but seriously strengthen their corporate practice of medicine doctrine. That is a really big trend that is sweeping the nation, in large part thanks to Mitch Lee.
Yeah, can we get Mitch into this conversation?
Yeah.
Mitch, maybe talk a little bit about Oregon, Mitch, and just sort of what Mo put out there, this idea that you can create common cause between the rank and file and folks with a little more, frankly, a little more prestige and authority, and well, may not always feel like authority, but status within the system. And I will note my own experience here. The Office of the Health Insurance Commissioner, which remains after 17 years, the only cabinet level health insurance regulatory position, was created in Rhode Island, not because of some super insightful legislature, but because the Rhode Island Medical Society announced a day off from healthcare and had a bunch of physicians in white coats walk up in the legislature. They were so shocked they had to do something, and so they formed this new regulatory function. So is there something to just, I'm mad as hell and I won't take it anymore, so organizing some of the docs?
I think we are absolutely reaching there, and you don't have to cut Maureen Tasic off when she's saying nice things about me next time. Yeah, no, I think there is a breaking point, but at the same time, I would love the folks in this call to sort of differentiate the physician who's coming out in my generation or a little younger with $300, $400, $500,000 in debt and being birthed into a world where you have one option of an employer and maybe you want to try to have a family. We don't have the power that people think we have. The people who have the power are the ones who sold us out. And within our profession, there are plenty who sold us out in various different ways. And to talk about the type of legislation that's going on in Oregon right now, which is very exciting because it is the first legislation to strengthen the corporate practice of medicine doctrine and prohibition in a state in half a century at least. If you look back, we're talking about 1950s, or pretty much the last time that there was any Supreme Court decisions or anything. And then in the 1960s and 70s, basically business people came along and said HMOs are going to solve everything and we'll make things very equitable. And here we are in 2018 with healthcare expenses quadruple as a percentage of a GDP since they were in 1980 after all of these actions against the medical profession took place. And frankly, there is something to be said. We went to 4 years of undergrad, 4 years of medical school, 3 or many more years of residency training. And right now we're basically being told that we're the problem and we should be fine with a fraction of the training, and doctors are the problem, and we need these corporations to come save us. And so big tech, Amazon, hospitals, insurance companies, everything has completely commoditized us and boxed us into the world of providers, as if we went to provider school. It's a shitty feeling. So there are laws, and I will tell you that pretty much the entire house of cards of corporate medicine rests upon a very simple linchpin of using a physician to pretend that these corporations own these practices in almost every state. And that requires a physician to essentially sell out their license and say that they own it on paper. And then the corporations strip them of power legally, like a stock transfer restriction agreement, and say that you own they basically put a figurehead physician, captive physician, friendly PC. That's the whole mechanism of it. And now you have corporations controlling the practice of medicine from top to bottom, while at the same time there's a push to replace physicians altogether. And this is a sensitive topic, but it's real, with non-physician practitioners with a fraction of the training. And the idea is that corporations can more easily control those populations with much less training. And this is not unique to the medical profession. We're talking about hospital techs reading EKG machines or telemetry that don't have training in that, decreasing standards for training for bedside nurses, moving to hospital at home and using EMTs and paramedics or basic techs, or replacing all of us with AI. It's a race to the bottom right now. And we hope that the concept of CPOM, and if we actually bring back some ethical standards to the profession of medicine so that we can't act as paper owners and we disrupt these existing laws that haven't been reinterpreted in over half a century, that we can flip the board of this otherwise completely unsolvable disaster of our healthcare system.
And so maybe before we do one final go around, because we only got 5 minutes left, Michael, I would be curious. You actually have some levers. We're talking about the organizing for sort of a mass movement, and you're talking about community organizing. But could you speak to the group a little bit about your experience? You actually had some levers. Rhode Island has some pretty strong legislation around changes of control. Our current Attorney General here in Rhode Island has actually used it quite well to make sure that Prospect Medical, another private equity company, was tithed before they could do some of their transfer. Something, by the way, that Connecticut, which also has Prospect-owned hospitals, missed the boat on. And so Rhode Island's in considerably better shape than Connecticut. So there are state levers that couldn't be used. I put something in the chat a while ago. What's been your experience with using them? Is it, yeah, talk about that a little bit.
Well, I think using them depends on the presence of an active and engaged leadership who's willing to go out on a limb and use them. On the hospital side, I want to mention that Rick Brooks, who's on, put something in the chat about the nurses union involved in the creation of the Hospital Conversion Act in Rhode Island. But it was, in my memory, it was more than just the nurses union. There was a big organizing effort in about 1980 to prevent for-profit hospitals from coming into Rhode Island. And that created both the Hospital Conversion Act and led to the creation of the Health Insurance Commissioner. So that's where Yael's perspective that we need to organize. Organization makes this doable. Chris, you'll remember that when you were the Health Insurance Commissioner, there was an attempt, probably from the hospital side of the world, to eliminate your position. And a lot of people came together to defend that. And it was that organization that kept that position secure. So, I think I actually had some experience working the regulatory side pretty hard and running into some corporate attempt to pull the rug out from under me. Pretty effective corporate attempts. Regulation is really important, and having the statute is really important, and having creative and energized people in those positions, doing things the way you did when you were the Health Insurance Commissioner is all really important. But that stuff needs a broad base of involved political support, political in the good sense, not partisan, but a good base of people who are paying attention and can come to the fore to support the good things that need to happen when an enlightened regulator uses their statutory power that she or he has at their disposal. I don't know if that answers your question.
Yeah,
but
no,
I think
it does.
it's complicated.
And I don't want to hold up our folks here who've been very generous with their time. So I'm before we thank the panel, lightning round, each of you has about 30 seconds to give a concrete sense of action around what folks who care enough to take a Wednesday evening after dinner in most parts of the country and listen to this, what can they do to prevent this from getting worse? Go first, Mitchell.
Oh, good. All right, I'm up there. So, thanks. So our website is a simple answer right there, takemedicineback.org. But what we're calling for is essentially three things. A return to the corporate practice of medicine doctrine basics and strengthening of CPOM prohibitions state by state and on a national level. And second is more protections for physicians, but all healthcare workers who are on the front lines, and as far as work protections and whistleblowing protections go when they raise concerns about patient safety and patient care. And I'll just allude to Mission Hospital right now, where they were put under immediate jeopardy by CMS, and they, which is like 2.4% of hospitals or something like that, when they're investigated by CMS. It's the most serious version of an issue that CMS can promulgate, basically. And the plan of action from Mission HCA was basically, let's crack the whip harder on the nurses and the physicians and the healthcare workers. It was complete junk, and CMS accepted that. There was nothing about staffing it appropriately. So healthcare workers need more protections on every single level. And then in the meantime, unionization is, at least it has to happen against these corporations, because the rest of antitrust enforcement that we're going to need on a grand scale is not going to happen fast enough.
Thank you. Yael, what can consumers do? What are you telling Families USA folks to do to address the profit making, particularly short-term profit making, that private equity represents?
Well, we have been talking about it more. I'd be interested in talking with all of you about that more. I definitely would be interested in organizing and working, or if you have already organized groups working on this, I would like to join forces with you to think about what are the best solutions at the state and the federal level. I'm going to put my email actually in the chat now for everybody. But I've been super impressed looking at the chat, and obviously this is a really educated group. It's been an awesome panel, and I really, really have had a lot of fun, and I thank Michael for inviting me tonight.
Mo, 30 seconds. What should we do?
Oh God, I think what we need is mechanisms for stopping looting of hospitals. That's what, at least what I think about Steward. I think these mechanisms exist from state to state. I think that they're just rarely used. But this happens every few weeks with a community hospital, happens every day with the nursing home. CMS needs to stop paying hospitals and healthcare systems that are killing patients and stiffing their workers and mortgaging all of the surgical equipment. That needs to end. And there are plenty of laws on the books that that sort of makes some of the stuff a crime or some of it a civil offense, but there's just no money in enforcement. Rhode Island, I gotta say, you got a good AG there. He stopped the sale leaseback, but it's difficult to get there, and I think that it happens on a state level. So call your AG, make this a big make a lot of stink with your AG's office. Obviously, they've been trying to do that and gotten something accomplished down in North Carolina. So,
Right. And it's also good. There's some good dialogue in the chat about the power of the purse. To your point, Mo, but that with 2/3 of healthcare government finance, it'd be nice if government was a little bit more aligned. So, Michael, take us home, and then we'll wrap up.
First, thank you. First, thank you to all the panelists who are fantastic. Chris, to you for being willing to moderate this and having a strong hand and an outstretched arm to make sure that we stayed on, and to Brian Kaiser for pulling it together, and to John Wright for making it happen. So thanks to everybody for thinking about this and being concerned. For me, the solution is we got to build a movement like the civil rights movement or the anti-war movement, or the movement for marriage equality, something that stretches across the country, and involves lots of people in lots of places, so we can defend meaningful, valuable, personal, nonprofit healthcare in many different ways. Defend it against the corporate practice of medicine. Defend it against profiteering. Make sure all Americans have a primary care relationship, a primary care clinician, a great primary care practice in their own community. We think that starting with primary care is a natural place because everybody needs it, and it's something communities can afford, but we got to build a movement, and it's got to include everybody, and bring all our allies together, mobilize that work, and spread it across the country. Otherwise, their $718 million a year of lobbying is going to swamp us.
There you go. I want to echo Michael's thanks to the panelists and to folks for your interest and your commitment to this work. It's how we're going to build a health system that is fair and equitable and meets the needs of everyone in the country. So thank you very much. Keep up the good work.